Hello and welcome to today's webinar for mental health professionals, Anxiety and Depression Treatment for Immigrant, Refugee, and Asylee clients, featuring Dr. Rachel Singer. My name is Vicki Spielman and I am the Associate Director of Membership and Marketing at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer's audio system by default. If you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. All attendees should ensure they remain muted for the entire presentation to avoid background noise and distractions. You will have the opportunity to submit text questions at any time of the presentation by typing your questions into the chat box of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A session at the end of the presentation. For those who purchased CE/CME credit for this webinar, you will receive an email with a link to complete the webinar survey and post-test questions required to receive a CE/CME certificate shortly after the completion of this webinar. Please reach out to webinars@adaa.org if you do not receive this link. I would now like to introduce Dr. Rachel Singer. Dr. Rachel Singer is a licensed psychologist who specializes in trauma, anxiety, and multiculturally competent interventions for immigrants, refugees, and asylees. Dr. Singer practices at the Center for Anxiety and Behavioral Change in Rockville, Maryland, and also conducts asylum evaluations for individuals seeking asylum in the U.S. She completed her PhD in counseling psychology from Boston College. Dr. Singer completed a 2-year postdoctoral fellowship at the Kennedy Krieger Institute at Johns Hopkins School of Medicine. Dr. Singer regularly presents at national conferences, has published in academic peer-reviewed journals, and has published several book chapters on clinical recommendations for working with immigrants. She's received APA's Citizen Psychologist Award for her outreach and advocacy with immigrant populations. There will now be a brief moment of silence while I pass the presenter role to Dr. Singer.
Hi, everyone. I'm going to get started here. It is very nice to be here with all of you. If you have questions or comments throughout the presentation, again, please use the chat box. I look forward to hearing from you, and I'm glad that you are all here. So thank you for the introduction. My name is Dr. Rachel Singer, and I practice at the Center for Anxiety and Behavioral Change in Rockville, Maryland. I hope you are all very well. Okay, I have nothing to disclose. Sorry about that. No exciting record deals or movie contracts. I'm going to start with a little bit of a presentation overview here. So we'll do some introductions and provide some background about working with this population. We'll start with some mental health statistics and barriers to treatment. We'll review some treatment recommendations and walk through a case, and hopefully we'll have a good discussion at the end. There is a lot to cover here. Hopefully this is not the only training that you attend in working with immigrants, refugees, and asylees. It's intended to be part of a longer, larger conversation. And most of the artwork in this presentation, these are photographs from San Francisco, mostly of the Women's Building. A little description of what that is. Since 1971, the San Francisco Women's Center has represented and been guided by the belief that women and girls have the right to safe, joyous, and creative lives. So I thought this might be a good one, good backdrop for our presentation. We're going to start with location, where I'm located, physical space. We're also going to talk about historical context and family systems. I think all of these are really important to consider when working with this population. So I'm speaking to you from Maryland. This is land formerly inhabited by the Tutelo and Saponi tribes. John Smith visited Maryland in 1608. It was primarily inhabited by Algonquin-speaking native tribes. And these communities have since been devastated by disease, loss of land, and wars. The state of Maryland has currently and formally recognized 2 tribes, the Piscataway Indian Nation and the Piscataway Conoy tribe. Falakov talked about the notion of cultural borderlands, that we have to know ourselves, we have to know our own identities, we have to recognize the identities of our clients and look at the ways in which those identities intersect and overlap. So if our identity is here and our clients are here, it's like a Venn diagram. We may have areas of similarity and areas of difference. A little bit about my family and my history. Both of my grandfathers immigrated to the United States to avoid persecution in Europe due to their Jewish identities. My maternal grandfather, you can see him pictured here on his wedding day to my grandma. He was born in the 1800s in Europe, and he immigrated to the United States in the early 1900s at the age of 15. He was born in the country of Ukraine. And he was fleeing pogroms, which are systematic violence towards Jewish individuals. He was going to be conscripted in the Tsar's army, and there was an extremely poor survival rate, and so he wanted to avoid that mandatory conscription. In his hometown of Kamenets-Podilsky in 1941, 23,600 Jewish individuals were slaughtered over the course of 2 days by Nazi-backed forces. This was a precursor to the final solution, conceived by the Nazis to wipe Jewish individuals off the face of the earth. My grandfather immigrated to the United States seeking economic opportunity and safety. He immigrated through Ellis Island. He learned English, he became a businessman. He made enough money to get his parents and his siblings out prior to the slaughter in Kamenets-Podilsky. He got 2 of his 11 siblings out. And he also created a secret network of Jewish individuals to help other Jewish individuals escape the Ukraine and Russia. And he sponsored them in the United States. My mom, I think, is the only person I know who still uses the Yellow Pages. Whenever she goes to a new city, she always looks up her last name. And she's actually found some other families who have the same last name as my family. My grandfather forged paperwork for them. The reason I'm telling you this is that who we are, the stories we know about our own histories and our own stories of migration, this impacts the work that we do. This impacts our worldview, our history, our personal history, the history of our community. It impacts our clinical lives, and it impacts us as individuals as well. Let's start with defining some terms. When we're talking about immigrants, first-generation immigrants are those who themselves migrated to the United States. Second-generation individuals are those whose parents migrated to the United States. So I am a third-generation immigrant, meaning my grandparents migrated to the United States, but my parents' generation and my generation were born in the US. A refugee is an individual who has been persecuted or fears they will be persecuted on account of some aspect of their identity, their race, religion, nationality, membership in a particular social group, or as a result of their political opinion. They are unable or unwilling to return home because they fear serious harm. And Asylee is someone who is seeking protection as a result of this persecution, or as a result of the fear that they will be persecuted. 1/5 of the world's migrants live in the United States. As of 2018, this was approximately 44.8 million individuals. And about 3/4 of those individuals are documented, approximately 1/4 are not documented. The number of refugees being granted admittance to the United States has dramatically shifted over the past 4 years. From 2016, approximately 85,000 individuals. The proposed cap for 2020 was 18,000 individuals. So you can imagine the mental health impact that might have. If you're in the United States and you are a refugee and you're seeking asylum, you're not sure if you'll be granted it. It certainly can cause a lot of stress. It's important to know where individuals are immigrating from and also which regions they're immigrating to. So you can find your major metropolitan city here. And this is from the Pew Research Center. They have a lot of good information and stats, numbers of individuals immigrating to the US. For those of us who work with kids, Between 1994 and 2017, this population grew by 51% to 19.6 million, or approximately 1/4 of all US children. It's important to note that first-generation immigrants, kids, they're more likely to live below the poverty line than second-generation kids who are immigrants, and a higher rate live below the poverty line compared to kids who are born in the United States. There are a lot of unique stressors that are currently being experienced by youth. I highly recommend, again, if you work with kids or if you're interested in advocacy, the Michigan Center for Human Growth and Development put forward a report that looks at the impact of the mental health impact on the separation policies that are currently being enacted at the border. And APA also has some information and reports on this as well. When we think about reasons for migration, we're thinking both about push factors and also pull factors. So a push factor is a reason why an individual might want to leave their country of origin. It's unsafe, maybe environmental disasters, wars, or political unrest. They don't have enough opportunities for work or education, persecution or fears of persecution. And a pull factor is a reason someone might choose to migrate to a particular country or to a particular region, seeking specific opportunities, seeking family reunification, or seeking asylum. We are mental health clinicians here, so we're going to spend a lot of time talking about mental health specifically today. We'll start with the immigration effect. The longer an individual resides in the United States, the poorer their health outcomes. We know that for individuals who are immigrants, refugees, and asylees, the health disparities are very well documented. For example, including but not limited to earlier mortality, higher rates of depression, higher rates of psychoses, and they may experience multiple stressors related to immigration. Stressors and trauma related to the reason why they left their country, trauma and stressors related to the migration experience in and of itself, what it was like living in refugee camps or living in very unsafe situations while they're in the process of migrating, or stressors related to residing in their new country. For example, social isolation, experiencing racism for the first time, additional trauma, experiences of violence. And all of these stressors may be compounded by additional stressors for individuals who are also persons of color. Depression is a global problem on every single continent, and I can vouch for this anecdotally. One of my friends worked in Antarctica as a dishwasher, and he said, yeah, everyone's pretty much depressed here. It's a pretty lonely place. 264 million individuals globally meet criteria for diagnosis of depression, and it impacts disproportionately more women than men. There are an estimated 800,000 individuals who die by suicide annually around the globe. And approximately 76 to 85% of individuals in low or middle income countries receive no treatment for this diagnosis. Anxiety is also a global problem, impacting approximately 284 million individuals globally. For those who live in high conflict areas, it tends to, we see higher rates of anxiety among older generations. They may be more exposed to the stressors. Younger generations may have a little bit of a buffer from those stressors in the high conflict areas. Either they may not be as exposed to those stressors or they may not be as aware of them. It's important to know prevalence for diagnoses, but there are also some big and unanswered questions here. For example, are the tools that we're using that were to screen for these diagnoses, are they sensitive to different cultural manifestations for the diagnosis? And are individuals actually being screened in general? Certain countries may not be using the same screening protocol. If you look at this map, it looks like North and South America seem like pretty anxious places to live. But again, there are questions of how are we defining anxiety and how might it be manifesting depending on country of origin. The APA Task Force on Immigration put forward a very comprehensive document in 2012. And if you're working with immigrants, I strongly recommend you look this up. There's a long document and there's an executive summary as well. So one aspect of this report, they're looking at potential barriers to care. What prevents someone from being able to access mental health treatment? And we're going to divide this into a couple of areas: sociocultural barriers, contextual, structural, and clinical procedural. So there may be different cultural expressions of symptoms. One of my mentors was looking at the mental health experience of Haitian immigrants in the United States. And many of the individuals in her study were discussing stomach cramping, pains in their abdominal region, and they'd go to their primary care doctors who would say, "I don't see a medical reason why you're having these symptoms." And my mentor, this is Gerda Nicola, who's at the University of Miami, she found these were actually congruent with symptoms of depression. They were experiencing a very psychosomatic manifestation for their depression. We also need to talk about stigma. When I was a faculty member, one of my graduate students was looking at the use of mental health supports among South Asian graduate students. And she found that the rates of stigma were very high. Many of them who wanted to seek out mental health supports were deterred by their families, who said, "You don't need a therapist, you're not crazy." We also look at, what assessment tools are available, and are they culturally sensitive? Are they normed for these particular populations? And talking with one of our providers in the state of Maryland who works with refugees and mental health here, she said the largest problem that they run into is just the lack of interpreters. And we're looking for interpreters who are trained in mental health interventions, who are trained in working particularly with these populations as well. They may be ineligible for services due to being undocumented or not having access to insurance. There may be a high rate of misdiagnosis for their mental health diagnoses. Clinicians may have their own personal biases. And as I mentioned earlier, the interventions may not be normed for that particular population. So let's talk a little bit about some potential risk factors for immigrants, refugees, and asylees for mental health concerns specifically. Individuals who are female may have higher rates of mental health diagnoses. Being unemployed or having a high level of job dissatisfaction, coming from a low socioeconomic group. As I mentioned earlier with the immigration effect, the longer that you live and reside in the United States, 10 years plus is a high risk factor, and having poor physical health overall. And as you might imagine, any of these stressors could certainly increase mental health risk and may make someone more likely to experience mental health concerns. It's also very important when we talk about any population, particularly when we talk about immigrants, that we're also focusing on protective factors, elements of resilience. So these are internal or systemic factors that may bolster against some of those higher risk conditions. Having a high level of family cohesion or support within the family system, interpersonal support, not just from family, but also from community, living in an ethnically dense neighborhood, having neighbors who come from a similar region. Sorry? Oh, I think someone might need to mute their mic. Perceived acceptance by one's community, and how safe you feel and physically safe you feel in your community, and documentation status. Imagine, if you're undocumented, that would be an incredibly high stressor for many of these individuals. So let's talk about what do we need to consider when we're thinking about a clinical intervention. Well, first, we start with the identity of our clients. And it's important that we think about their identity across a number of different dimensions. Pamela Hayes proposed the addressing model, which looks at all of these different dimensions. The addressing model, we look at our clients' age or generational influences, developmental or acquired disabilities, religion and spiritual orientation, ethnicity, socioeconomic status, sexual orientation, indigenous heritage, national origin, gender. And we want to know how our clients self-identify. We also want to think about these factors for ourselves. Again, if we're thinking about those cultural borderlands, recognizing our own identity and that of our clients, where might we overlap or intersect? Where might there be perceived areas of overlapping? Clients may assume that they have something in common with us, or may assume that they come from a different background than we do. With each of these aspects of identity, we want to consider if they are a high or a low power position. And this is relative to other individuals who live in our communities or who live in our country. We want to recognize too here that a certain aspect of identity may be a high power position in some contexts, but may also be a low power position in other contexts, depending on who you're with. Now, our clients and we're not a series of boxes to check. And so we don't just want to look at each of these individually. We want to be thinking about intersectionality. So ways in which these various aspects of identity may overlap. And we'll talk about this a little bit more when we come back to the case in a moment. When we think about our clients' experiences, it's critically important that we think about acculturation. And this is Barry's model of acculturation, which looks at two elements. How connected is this individual to the culture from their country of origin? And how connected are they to the culture of the country where they're currently residing, of their host country? Starting with assimilation. So assimilation is where you might shift from the cultural habits or practices from your country of origin to those of your host country. And the ambition may be to adopt the kind of majority culture to kind of, again, shift your identity a little bit. Separation may be where you focus on maintaining the culture from your country of origin, but you may avoid contact with the culture of your host country. Integration may be a little bit of both. So adopting some norms and values from both your host country and from your country of origin. Marginalization refers to an experience where you may not hold on to either. And this may feel like isolation from both cultural groups. And for some individuals, they describe this as feeling like they don't feel like they fully belong in either culture. So when we think about our clients, we want to think about not just them and their identities, but also their larger environmental context. So this is Bronfenbrenner's ecosystemic model. And so we're looking at the individual, but we're also thinking about their microsystems. And on each of these dimensions, we're thinking about areas of support and resilience, but also potential stressors that might increase their likelihood to develop mental health symptoms. So microsystem are the individuals with whom they may interact directly, family members, their school system, employment. A mesosystem, those are interactions between those microsystemic units. So if we have a client who is a child, the mesosystem might be, how are their parents interacting with the school system? And we also want to be thinking about exosystems, so indirect environments, and the macrosystem. These are social ideologies, these are values and cultures and subcultures as well. APA developed a multicultural guidelines, set of multicultural guidelines. These are very extensive. This document is 212 pages long, so there's quite a lot to look at there. And this is kind of a summary of their model. They take the ecosystemic model and they expand on it. So in addition to that sort of ecological framework, they're also adding dimensions of power and privilege. They're looking at strengths-based perspective with this focus on resilience. They're looking at the impact of trauma. They're thinking about all of this within kind of a human rights perspective. And then we're thinking about both the client, but we're also thinking about the clinician and their sort of systems and their environment as well. So hopefully everyone here knows that evidence-based interventions are essential for treatment. We want to use research, and we want to use interventions that are based on research, where the research indicates this is a good tool, this is a good intervention for this population. You have probably heard of cognitive behavioral therapy. If not, I strongly suggest you look it up. It's a very strongly evidence-based intervention for treating both anxiety and depression. But we want to look for ways, in addition to using kind of the basic CBT interventions, for custom fitting them, for tailor fitting them to our clients' particular needs. So for example, we want to bolster CBT with other elements. CBT Plus, I'll talk a little bit more about that in just a moment. They found that close relationships with community groups, fostering a connection between the clinical setting and the local community, can enhance clinical outcomes. And then we also want to think about who is present, who are the clinicians, who are the providers who are treating these clients. Diversity within the clinical workforce can lead to more positive outcomes as well. There are many, many evidence-based interventions for working with immigrant clients, and consider this a future reading list for you. If you want citations for any of these, I'm happy to provide them. Please send me an email. But for example, there's CBT that is a trans-diagnostic, culturally adapted format for Farsi-speaking refugees. There are modifications of CBT that integrate cultural values. For example, respeto and formalismo for Latinx clients. There's a modular CBT for immigrant youth. TFCBT has multiple modifications. De Arellano has a TFCBT format that's adapted for Latinx clients. There's an Islamically modified CBT. Again, there are many different modifications here that build on the CBT principles and that also integrate elements of clients' culture and identity and found, very strong positive outcomes. I'm going to walk through one such intervention, and this is CBT Plus. So CBT Plus has 4 particular elements here. And this is pioneering in Washington State. And they're looking at, is this intervention, can it be congruent with our clients' beliefs? Can we align the intervention to suit our clients? Can we modify it to suit who our clients are and what their values are? We also want to think about engagement. What brought them into session? How can we enhance clinical outcomes? We look at using appropriate assessments and providing psychoeducation. And I'll walk through each of these elements now. When we think about engagement, we want to get a description of the symptoms from our clients' own words. And we want to instill some hope. We want them to know that help is possible and that a positive outcome is possible too. It's important to ascertain their past history of therapy and find out if they have any beliefs or past experiences with treatment. We can ask, have you or others have they had any experiences with therapy? Do you have any concerns about seeking out therapy for you or for your child? We want to recognize and identify potential barriers to treatment. For example, financial concerns. Do they have childcare so they can come to their own treatment? Are they able to get transportation to come to treatment? And if we're thinking about CBT and potentially CBT being a time-limited therapy, if they do have any barriers to treatment, we want to help them identify some short-term solutions that will allow them to attend therapy and to see those potential benefits. We also want to make sure that we give a clear and accurate description of the treatment that we offer. And we want to differentiate between our treatment, our evidence-based treatment, and any negative past experiences they may have had or any preconceptions. When we're engaging in assessment, in addition to our traditional diagnostic intake, we want to get a sense of their understanding of the presenting problems and concerns, any specific parenting or child rearing practices and how culture might play a role in that, identifying and understanding their gender roles, asking about their history of migration or immigration history, and if they're a 2nd or 3rd generation immigrant, we can ask about their family's history of migration. We want to assess their level of acculturation, find out about elements of community involvement. Do they have any current practices, celebrations, activities, supports within their community? What are their experiences of discrimination? Do they have any particular religious or spiritual beliefs or practices? And again, this can fold into those elements of resilience. What are their views of mental health and mental health treatment? And what are their preferences for language? We want to make sure we're practicing therapy in a language that best suits the client, where they can communicate most fully about their experiences. Psychoeducation is bidirectional. So we provide information about the treatment that we're providing, but we are also asking questions. And we want them to be able to share information about who they are. So we can attend a training about client population from a particular background. But again, thinking about intersectionality, thinking about the differences that may exist within communities, we want to make sure we really fully understand our clients. And we want to make sure we get their client's perspective of their symptoms. So for example, if we are working with a family and a child is our client, and the parents say, my child is very disrespectful, and they come from a community where respecting elders is critically important. We may both want to listen to them and hear their concerns about this, provide some information about developmental expectations, why might their child be pushing back? But we may also want to talk with our client about what is the impact, when you are asking for more, you want to be more separate from your family. You come from a collectivistic culture, how might your parents perceive that? They perceive that as disrespect, whereas for you, this feels like a way of creating a new identity. And so we may want to include both of those perspectives in our clinical conversations. Psychoeducation is hugely important when we think about, it's a great opportunity to normalize symptoms, to validate our clients' experiences, and to also instill hope. Engaging exposures is very important for helping to reduce anxious symptoms. But there are some fears or worries that have a historical or a cultural context among marginalized groups, especially those who have been victims of discrimination, bias, stigma, and they may have experienced disproportionate levels of violence within their communities. So we want to ask about experiences of discrimination or harassment or mistreatment. So if they tell us they're afraid to go out, to leave their home, they're afraid to be outside, we might want to ask about that. I understand you're really scared when you leave your home. Have you had experiences where you've been treated in a frightening way because of your background? Can you tell me about that? And when we think about behavioral activation, when we're thinking about depression, we want to use a strengths-based perspective here. So if they're coming from a collectivistic culture, can we incorporate their family, their community, their elders into our interventions? Can we help them find ways to bring joy into their lives, to maintain feelings of connection to their culture as well? When we're thinking about trauma, we want to understand how a client's culture might impact the way in which they process trauma. For example, some cultures may process certain events as community traumas and others as more private traumas. So a natural disaster that many people experience may be perceived as a community trauma, whereas a rape may be perceived as a private trauma. And so there may be additional layers of secrecy or shame or stigma with talking to a clinician about the experiences that they've had. We also want to recognize the role that historical trauma or intergenerational trauma may have had on the family system and on our clients. The American Academy of Pediatrics has a really lovely list here of different screening tools that are normed either for the general culture or specifically normed for working with immigrant, refugee, and asylee populations. If you're using a tool, look to the research and find out, has this tool been assessed for the particular population that you're working with? And if it hasn't, is there a more effective tool that would be better suited to who your client is and who their identity is? When we talk about mental health interventions, we always have to talk about ethical considerations. So APA has a lovely ethical aspirational code, and you'll see that on the left side of this column here. But let's talk about some practical ways that we can actually apply it. It's critically important that we engage in peer consultation and supervision to maintain neutrality, to properly identify and check our value systems. We may have responses to our clients if they come from a background that is different from ours. And we want to recognize, are our responses related to our own perspective, our own culture? Is this actually something that is a pathological concern? We want to be engaging in frequent reflexivity, particularly about culturally sensitive topics. So there may be some topics that a client is talking about that are considered to be normative for their culture, but they may be something that feels surprising or shocking if you come from a different background from them. We want to learn about our clients' value systems. We want to ask them questions about this. We want to seek out professional training opportunities wherever we can. You are here today, which is awesome. But again, this should not be the only training you seek out when thinking about working with immigrants, refugees, and asylee clients. When you're talking with your clients, you always want to review any benefits and any drawbacks of any treatment. We want to fully disclose that to them. We don't want to provide false promises or guarantees. You will definitely get better. This will definitely work. We don't want to do that. There may be a healthy mistrust of authorities. If they're coming from a community where authorities have actually been harmful to them, they may not trust the clinician. They may not trust you. And so you want to recognize that comes from a normal and adaptive perspective, an adaptive place. Again, we want to recognize our own potential biases, ensure that there are adequate norms, and that we're using evidence-based treatment. We want to recognize the boundaries of our own competence and understand intersectionality, both in terms of our clients' identities and our own. And we always want to work to protect vulnerable populations. So we may not have adequate training on every single cultural group, but there's a question, are we well informed about a similar culture? Do we know the bounds of our competence? Can we seek out peer consultation or support? If there's a client for whom we do not have the proper training, can we ensure that we're going to refer them to someone who may be better suited for that particular client? We want to identify and resolve any personal problems we may have that may impact treatment. For interruption of services, asylee and refugee clients may be a very transient population by necessity. So we want to make a plan ahead of time if they need to move suddenly. How will they contact us? How will we help them find a provider if they're in an area in which we are not licensed? When working with interpreters, we want to make sure those interpreters are properly trained, that they have a background in working with mental health clinicians, that they understand a little bit about potential boundaries of their own competence. We talk with them and our clients about confidentiality. And whenever we leave the room, the therapist should leave the room as well. Once our clients feel more comfortable, they may start talking with the interpreter. We want to make sure we don't miss any clinical information. Regarding informed consent, this should always be clear, easy to read, easy to understand, translated if need be, and we want to avoid unnecessary jargon. If we're working with a client from a collectivistic culture, we want to clarify who is the client. If we're working with a group, we want to clarify who the client is as well. And if we're working with a family, there may be multiple needs that different family members have. And so we want to be able to ensure that we can provide for all of their needs. We always want to avoid pathologizing clients for normal responses to a maladaptive system. So if they're experiencing racism, if they're experiencing xenophobia, we want to recognize their reactions may be incredibly valid and may be adaptive and protective. It's helpful to think about ways of blending particular approaches. So I worked with a young man from the Dominican Republic. His family identified as Pentecostal Christian, and he was reporting that he was seeing El Diablo. So he was having frequent visions where he was seeing the devil. Now, in his community, in his church, people frequently reported this, and there were many exorcisms. Now, for this young man, these experiences were not comfortable. They were very scary and frightening for him, and they prevented him from being able to learn and focus in school. El Diablo would show up at very inconvenient times, and he was very frightened by it. The family had a strong mistrust of their first psychiatrist. The mother thought that the psychiatrist was prescribing pills to poison her son. And so it was important for them to find a new psychiatrist, one who was actually identified as Latinx himself, who spoke Spanish, was able to answer mom's questions. Now, the family's church was an incredible source of support for them. And so they actually went ahead with both medication with this new psychiatrist, but they also proceeded with an exorcism. And the young man reported, and his family reported, that he felt a lot of relief related to his symptoms, but we can blend those approaches. We also want to recognize we may need to adapt our role as a clinician. There may be times where we're engaging in somewhat of an advocacy role, and we can talk about that too. We want to recognize their language preferences for treatment, and also recognize just the constellation of stressors related to the immigration process. It may heighten their overall levels of depression and anxiety. Couple action steps here, and then we'll jump into the case. So wherever you are, identify the populations in your geographic region. Who are you likely to be working with? And seeking out appropriate training for working with that population. Engaging in outreach about mental health awareness, you can help destigmatize mental health treatment. In the Maryland region, there's a wonderful organization called the African Affairs Advisory Group. They work very closely with leaders in religious organizations and cultural leaders as well, some of whom have degrees in mental health, some of whom are perpetuating harmful stigma about mental health, about HIV. But by engaging in that outreach, we're able to both ascertain what are the needs of that community, and we're able to provide some information. We're able to kind of shift the focus that seeking mental health treatment is not something scary, that we are people who are approachable. I strongly encourage you to network, find a network of clinicians who are working with similar populations, who are working with immigrants, refugees, and asylees. Conducting asylum evaluations is one of the most wonderful and challenging parts of my job. If you're interested in learning more about this, please let me know. This is a separate training for another day, but a great way that we can support this population. And engaging in advocacy on our clients' behalf. At the state, local or national levels. So let's apply all of this to a case. Luis is a 36-year-old first-generation immigrant from Mexico. He was referred to therapy after a recent work injury in which he fell off a ladder, resulting in extensive hospitalization and surgeries. He described symptoms of panic, rapid heart rate, difficulty breathing, avoidant behaviors regarding being in high places, including not wanting to climb stairs, not wanting to drive across bridges, and he lived on one side of a bridge and his work was on the other side, and so he wasn't able to cross that bridge. He was also afraid of elevators. Luis was afraid to press charges against his employer due to his status as an undocumented immigrant, and he cited a broken rung on his employer's ladder as the reason that he fell. But again, he was afraid that if he reported this, he would have to leave. He attends therapy with his wife, Martina, who only speaks Spanish, and Luis is bilingual. He's requested that the therapist conduct the interoceptives and the exposure therapy in English, and he's also very concerned about losing his place as the primary earner of his family and losing the respect of his extended family. He's also told his wife not to let their 6-year-old daughter play outside in case she herself falls. So his extended family was asking a lot of questions. You know, your physical injuries, you seem healed. Why aren't you able to go back to work? And his wife had started working in a cleaning agency to cover the family's daily expenses and clothes and food for their daughter. He was a very loving father, but he had started to withdraw from his immediate family after this incident. So as I mentioned earlier, we want to respect and value our clients' linguistic preferences, right? And so, you know, I did conduct interoceptives in Spanish. And by the way, names of this client have been changed, identifying information has been changed. But we did have some psychoeducation in Spanish, and he was okay with that. When we think about incorporating family into treatment, it was a lot easier for him to be vulnerable in the therapy room as opposed to at home. And he allowed his wife to see him having emotions. He allowed her to kind of see some of the panic symptoms, and he allowed her to see, you know, when he became very tearful. And she mentioned frequently, you know, he doesn't talk about this stuff at home. It could be possible to, you know, also ask if he wants his extended family to come to treatment as well. So I provided a lot of psychoeducation for the family. And you know, you can ask him, do you want others to be present for this information? We talked a lot about the role that his culture played and how important his family was. You know, he's used to being the primary protector. He's used to taking care of his family. And so he had lost a lot of power with this injury. We talked about his, you know, his role as a Latinx individual, but also as a man. And we thought about, you know, are there ways of reframing coming to therapy in terms of a strengths-based perspective? Allowing himself to be vulnerable was a way of showcasing his strength and allowing him to regain access to employment that he, you know, was very much a part of his identity. So the family is undocumented. And so as a clinician, you know, we may think about our role as being, you know, primarily therapy, but we can also think about extending the bounds of that. You know, can we think about advocacy? Can we think about connecting him to resources related to his documentation status? And this was a huge stressor for him. So individuals who are undocumented and live in the United States, they're oftentimes plagued by fear and uncertainty. The unpredictability, the sort of marginalization, the xenophobia, you know, all of those compounded those particular stressors. And so, you know, when engaging in exposure hierarchy with his family, you know, his wife and daughter became an integral part of this. And his daughter would help him practice this. And one of the exposures was allowing his daughter to play outside in the cold, in the ice, you know, in the snow, and allowing her to go ice skating, you know, which is a situation where there are a lot of falls. And that was both, you know, terrifying for him, but also very empowering as well. I'm going to pause there. I want to make sure that we leave time for some discussion about this case in general, or about any other questions that might come up. And so I'm going to ask if we have any questions in the chat box.
Great. Just as a reminder, everyone can still submit questions through the chat box. I don't see anything yet, but if you do have questions, please go ahead and enter them now.
And if you don't have questions, please also feel free to share if you have any resources that you found related to evidence-based treatment, or any modifications that you found to be particularly helpful in using CBT or trauma interventions. How are you modifying your interventions and working with immigrant clients?
Dr. Singer, I do have a couple people asking about the PowerPoint. We can share it with you. If you, I'll put my email address in the chat box. So if you would like that, just send me an email and we'll get it to you.
Wonderful.
Please feel free to enter any other questions.
And if there aren't specific questions, I also didn't talk too much about asylum evaluations, but I can share a little bit of information about that. So if you're interested in asylum evaluations, these are for individuals who are oftentimes referred by their lawyer. And again, they're seeking asylum in the United States because of a fear of persecution or experiences of persecution. They are exponentially more likely to be granted asylum in the US if they have a medical or psychological evaluation. And sometimes these are, the goal is the Istanbul Protocol. We're looking at consistency. So are their symptoms consistent with the trauma that they're reporting? Or are their physical injuries consistent with the trauma that they're reporting? And the physical injuries would be more along the medical side of things. So frequently what will happen for an asylum evaluation, the Physicians for Human Rights is a great organization, does a lot of pro bono asylum evaluations, and it's a good place to start for training. But an individual, like their lawyer, will contact Physicians for Human Rights or a similar organization. They'll connect them with a clinician, and frequently it's a multi-session interview where you're getting a sense of the individual's pre-trauma functioning. What was their life like before the persecution? And many of the individuals I work with experience torture as a result of some aspect of their identity. And so, again, we're looking at kind of the pre-trauma functioning, and then we're asking them to sort of share their story. We're kind of clearly recording what is their reaction to sharing the story. I see this as a great opportunity to provide psychoeducation for lawyers and judges about symptoms of trauma. Sometimes when someone gets into a courtroom and they don't remember an aspect of their persecution in their country of origin, or they don't remember a particular detail, or the facts change, we can share information like that in the report about how trauma gets encoded, or how somebody might process an event. They may misremember, their brain may not encode it as clearly, or judges may also say, this person doesn't seem that upset by these events. How can this be true? And so we can talk about symptoms of, depersonalization, derealization, that some of this sort of limited emotional expression is a normal response to what they've experienced. It is not the same thing as therapy. Oftentimes, most organizations will have someone, they'll refer out for an asylum evaluation so that you can provide a slightly more impartial perspective. And then the hope will be, for most of these individuals, they will need therapy. They're experiencing depression, anxiety, PTSD, secondary to their experiences. And the hope will be to then ensure that they've got some good continuity of care and to refer them back to someone who can provide that ongoing treatment. There are some organizations that encourage people to both provide the asylum evaluation and to conduct therapy, because they may say it's harder to malinger over multiple sessions. And so there are some slightly different schools of thought in that area.
Great. We do have a couple of questions. I'm going to apologize in advance. It seems like we have a big thunderstorm rolling through. So if you hear some thunder in the background, I apologize. The first question, with treatment for Luis, is it more focused individually or family with wife and family present?
That's a great question. So I did kind of a hybrid approach for him, where again, we're doing the interoceptives for the panic symptoms, and we created the exposure hierarchy, but his wife was basically present for, I would say, 90% of the sessions. And typically when I'm working with a client or an adult client, I may only be meeting with that individual, but it was helpful for his wife to see him in the context of those interoceptives, in the context of that exposure hierarchy, to see him have the panic symptoms and to see him come out on the other side. So we did a lot of debriefing with both of them, but I provided a lot of information about here's what you're likely to see, here's what this means, here's what this does not mean. No, he's not having a heart attack. These are really normal symptoms that we experience, when we're kind of remembering a particularly difficult event. And so, his wife was very encouraging, and oftentimes, she would ask questions before and after the treatment. I did not meet with the daughter, but again, the daughter became an integral part of some of those exposures at home, because Luis was both scared about himself and falling. His injuries were incredibly severe, and he was very lucky that he survived. But a lot of his fears about falling were related to his wife and daughter, and so not wanting them to be unsafe. And so his daughter was more than thrilled to be part of his homework when he went back to her. She's like, oh yeah, I would love to go ice skating with you. And it was also fun for her to see her father, start to regain some feelings of control over his own life.
Okay, the next question, not all therapists consider these characteristics when talking to clients. What is your experience advocating for inclusion among other therapists?
That is such a great question. Whoever asked that, I hear you, I feel you. As you can probably tell, I identify as white. I have worked in many contexts where the clinicians identify as white, and they're working with minority immigrant clients. My dissertation was on this, white clinicians who are working with minority immigrant clients. And a lot of the sort of statements I encountered, there would be things like, this client is not psychologically minded. They are not suited to psychological treatment. And the problem is not that the client is not psychologically minded, which is a very pathologizing thing to say. The problem was that the treatment tool was not valid. And I think part of this is, again, going back to evidence-based research, to be able to sort of go back to the data. And sometimes it helps to make it feel a little bit more impartial if you say, well, hey, like here's an intervention that I think may be even more effective. You may help the client sort of see the results that you're hoping for and they're hoping for if you modify this. I think it also starts from 3 dimensions: knowledge, awareness, and skills. So knowledge about the clinical interventions, about our client's background, awareness of our identity and their identity, and then skills being the actual tools. So can we carry this out? Recognizing that we and our colleagues may have different levels of knowledge, awareness, and skills for different clients. And so if this is someone with whom we can provide consultation or supervision, that's wonderful. I always like the opportunity to be vulnerable with my colleagues, with my trainees. I'm the director of our postdoctoral training here, and I love telling people I don't actually know the answer to that. And so it's okay to model that. It's also okay to, just as we do with our clients, with our colleagues, to use a strengths-based perspective. I know how much you care about this client. I know how eager you are to help them. Have you thought about this? Asking questions. I wonder whether it might be helpful to, integrate some elements of this. And then if you have expertise in this area, providing trainings for your colleagues at your workplaces, providing trainings for colleagues at other places as well. Again, I think the more that we can create a network of evidence-based interventions that are multiculturally competent, the more our clients will benefit.
Okay, I think we have time for one last question. If conducting therapy with a patient while using an interpreter, do you know of a resource where therapists can access psychoeducation or homework handouts, common symptom measures that have been appropriately back translated?
Again, excellent question. And I think the translated and back translated, so if a measure is in English, that means you translate it to Spanish and then you translate it back to English and you say, like, has it maintained integrity? I don't think there is one resource for interventions that have been appropriately translated and back translated. And I don't want to assume homogeneity of any particular population. So depending on the culture, the country of origin, those other aspects of identity and the addressing model, We want to make sure that we are looking for measures that have been translated, translated, that have been normed against other measures that already exist. I wish I could tell you there's this one resource for all of those measures. The American Academy of Pediatrics, that list, may be a good starting point if you work with kids, but I don't have one, just one resource.
Great. Thank you, Dr. Singer, and thank you to our participants for attending today's training. We would like to invite you to register for ADAA's next live webinar on September 24th, Socratic Dialogue and the Collaborative Empiricism, Practical Strategies to Overcome Common Pitfalls with Dr. Scott Waltman. We also invite you to visit ADAA's website, www.adaa.org, to view all upcoming live webinars, as well as our full library of on-demand webinars. If you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer. ADAA members enjoy year-long access to continuing education programs, many CE eligible, free access to special interest groups, including online peer consultation groups, promotion of your practice in ADAA's online Find a Therapist database, significant discount to ADAA's annual conference, website listings of your clinical trials, support groups and publications, and much more. Please visit adaa.org to learn more. On behalf of ADAA and our presenter, we thank you for joining us today.